Hello and welcome to lecture number 29 in Drugs and Human Behavior. We're starting a new section on depression. In this first lecture, I'm going to do a basic introduction to depression, and then I will go through different types of treatment and options for preventing and treating depression that don't necessarily include pharmacology. So we'll start off in this lecture with an introduction to depression. We'll then talk about, in later lectures, first-generation antidepressants, selective serotonin reuptake inhibitors, other reuptake inhibitors, talk about ketamine and psychedelics, a sort of new frontier in this area, and spend a little bit of time talking about the latest research on ketamine and its effects on the brain. And then finally, we'll finish up with alternatives to drug treatment, in particular talking about ways in which we can think about using diet and exercise to prevent depression. Let's start with an introduction to depression. We'll start with a discussion of the efficacy of antidepressants, talk about depression, and then finally finish up with the pathophysiology of depression and introduce the modern view of depression that is not one of a chemical imbalance, but one of neuronal neurogenesis and neural functioning. So we'll start with the efficacy of antidepressants and what the goals of treatment are. They are to alleviate symptoms and distress associated with depression, also to relieve anxiety and or combined anxiety and depression. Anxiety and depression are often comorbid. In fact, anxiety and stress are one of the primary causes of depression. And so when we talk about depression, we're generally talking about anxiety and stress as well. We want to relieve those symptoms. We want to improve the quality of life for patients so that they're feeling better, they're able to get out and do the things they want to do. We also, however, want to try to repair the neuronal damage that's associated with depression. And this is where we start understanding a lot more about how we can take a different approach to understanding treating depression, because repairing that neuronal damage is really the most important part of treating depression. And that's why we see the effects of drugs like ketamine, while we also see effects from things like exercise and changes in diet and ways in which they can help repair that neuronal damage. In terms of the effectiveness of antidepressants, depression generally only modestly improves with treatment. Certainly, the side effects associated with antidepressant treatment can cause their discontinuation. In particular, they can be associated with weight gain, can also be associated with sexual dysfunction and other issues. There are limited effects on improving cognitive functioning. One of the hallmarks of depression are reductions in memory, and in particular, attention and working memory. And one of the things we want to try to improve in depressed patients' lives is their cognitive functioning, because it's an important part of this overall picture. Importantly, the magnitude of the response of an antidepressant is related to the severity of depression. For people with mild to moderate depression, you don't get a significant response to antidepressant treatment in terms of symptomology. Now, it's possible that treatment prevents a slide into more severe depression by responding to those neuronal changes that we'll talk about. But this is the stage at which perhaps some lifestyle interventions might be appropriate to try to treat that depression with something like exercise. So if we look at antidepressant efficacy, these scores on the bottom indicate the depression at intake, and so the higher the score, the higher the depression. And what you can see is the antidepressant depressant medication change is this blue line plotted here versus the estimated placebo change. People do respond to placebo. And what you can see is an improvement primarily at the higher end, certainly at the upper half of these scores, whereas we don't get much improvement in the lower half of scores. So that improvement really generally occurs in this moderate to severe depression. One of the things we've started seeing is some combined therapies. Treatment-resistant patients are often prescribed an additional drug. This most often just increases side effects and does not actually improve patient outcomes. Combinations of drug treatment with psychotherapy show little additional benefit to either on their own. So drug treatment or psychotherapy, adding one to the other doesn't seem to add one to the other. So that gets us then to thinking about really what depression is. And depression is what we call major depressive disorder, which is a chronic, recurring, and potentially life-threatening illness. And that's something that's really important to keep in mind. Depression is a life-threatening illness. We live in an era of a serious problem of suicide, particularly younger people, returning veterans. A lot of at-risk populations are really at risk for suicide. And so we really need to treat this as the life-threatening illness it is. This is an affective disorder with alterations of both emotional processing and mood. We see decreased interest in pleasurable activities, oftentimes an inability to express pleasure, certainly not to the extent that might have been previously possible. We often see sleep difficulties, and those sleep difficulties can compound depression. We know sleep loss is a major risk factor for depression. We also see fatigue or loss of energy. The treatment for that depression fatigue, oftentimes the antidepressants will do that on their own. There is another drug called modafinil, which has been shown to be efficacious in reducing the fatigue associated with depression. Then we get to the serious symptoms, feelings of worthlessness, excessive guilt, and possible thoughts of death or suicide. And so this is a very serious illness. If you or somebody you know are suffering from one of these disorders or any of these symptoms, please reach out and get some help. There are plenty of places where you can talk to someone. There are plenty of hotlines. Make sure that you're taking care of yourself and others. Important to understand that depression is often induced by stress and anxiety. And in fact, the index episode for depression is almost always a significant stressful or anxiety event. And so these risk factors are particularly important for us to think about, both how the body is responding to stressful events and the type and severity of both stress and anxiety. Finally, depression is associated with reductions in attention and memory. People who have depression oftentimes have difficulty concentrating and oftentimes have a lot of difficulty with their memory as well. So if you know somebody who's going through this kind of depression, be patient with them, help them out, and keep in mind they might have forgotten something because of this illness. That gets us to the pathophysiology of depression. Most of us were trained in what we call the chemical imbalance theories. And in fact, most people still talk about chemical imbalance theories. This historic explanation of depression was an imbalance in neurotransmitters, particularly serotonin. But we see that the drugs we use today boost neurotransmitter levels quickly, but it often takes weeks, often for symptoms to improve. So our attention has shifted to the long-term effects of these drugs on neurons and particularly neural circuits. And what we're starting to see is it's actually the neurons themselves, not the serotonin, that are the underlying factor here. That gets us to the neurogenic theory of depression. We've seen that antidepressants alter functioning of secondary messengers within a neuron. And so this isn't simply increasing the amount of synaptic serotonin available, but actually altering the long-term functioning of a neuron. These functions include protecting neurons from damage and promoting and maintaining the health of newly formed neurons. So one of the things we see in depression are reductions in the number of neurons, reductions in the creation of new neurons, and reductions in what we call dendritic spine density, which is an important part of how neurons function. And so we see reductions in healthy synapses. And so by changing these secondary messengers, we can see increases in new neurons and the health of neurons and a reduction in the loss of neurons. When we talk about neurogenesis, this is the creation of new neurons. And primarily in depression, we're talking about the hippocampus and frontal lobes. And so these are two areas that are particularly important for us to look at in terms of trying to understand how depression is caused and how to treat it, and places we can look to see how these neurons are functioning. So this is particularly important in depression, as many functions associated with these particular brain areas are affected by depression. So attention, concentration, and memory. These are all areas that are part of the hippocampus and the frontal lobes. So the hippocampus is primarily associated with memory. Attention and concentration are primarily frontal lobe functions. The hippocampus is part of the limbic system, which is associated also with emotional regulation. And so this is an important part of understanding this overall process. We also know that neurons in the hippocampus are especially susceptible to trauma. So we've seen in people who have, for example, a loss of oxygen, we get a loss of neurons in the hippocampus. In this particular case, we're talking about the effects of the stress hormone cortisol. So when you have a stressful event, your brain gets kind of flooded with cortisol, your whole body does. And these neurons in the hippocampus and the frontal lobe seem to undergo a great deal of damage from that cortisol release. So if we start to think about the effects of stress on something like the hippocampus, mild stress is okay. If those of you who remember the Yerkes-Dodson effect, where a little bit of arousal is good for us, makes us function better. So a little mild arousal, alertness, gets us functioning pretty well. Once we start to get into moderate stress, we get reductions in activity. And then once we get out into a strong level of stress, we get changes in the overall morphology of the hippocampus, changes in dendritic spine density, size of the cell bodies. And then when we get out into chronic stress, we're now into neurotoxicity, death of neurons, and reductions in neurogenesis. And so these stress effects are a primary cause of depression in most individuals. So stress, particularly high stress events, cause increases in cortisol. Cortisol is manufactured by the adrenal cortex located atop the kidneys. It's our primary stress hormone. And that cortisol is known to reduce frontal and hippocampal neurogenesis and damage existing neurons, in particular reducing what we call dendritic spine density. So the dendrites of a neuron are the receiving ends. And because those dendritic spines get reduced in their density, we see reductions in the capacity of that neuron to receive signals and to function. And so that reduction in neuronal functioning is actually the primary cause of the mood disorders and fatigue associated with depression. So if we look, you can see here in the top, the control versus stress spine density. If you look at the control, pretty dense number of dendritic spines. Following the stress of the induction of cortisol, you can see in the one-mark stress, pretty significant reductions in the number of dendritic spines. You can see those spines per 10 micrometers is significantly reduced. And you can also see that effect of cortisol on those neurons. So stress reduces the number of dendritic spines in branches of neurons in the CA3 area of Ammon's horn, which is a layer of the hippocampus that's important and associated with a variety of functions. It also suppresses the production of new granule neurons in the dentate gyrus regions of the hippocampus. And the dentate gyrus is an important part of the hippocampus for creation of new neurons. So these structural changes to the hippocampus following stress appear to correspond to the deficits in spatial navigation and episodic memory produced by stress. And so stress is causing this kind of neuronal damage because of that release of cortisol. So one of the important things to keep in mind as we move through some of these new upcoming lectures is anything that might alter that stress response can be protective against depression. So one of the things we know is that exercise helps protect the brain by causing reduced releases of cortisol during a stress response. So when you have a stressor, you don't get this flood of cortisol like you would have without the exercise, and as a result, you get less damage. And that's one of the important effects of exercise. So a couple other things to keep in mind that go along with this line of evidence. A post-traumatic stress disorder is associated with reduced hippocampal volume, as is a history of being a victim of abuse. We've seen that antidepressant treatment can reverse hippocampal shrinkage and dendritic spine loss. And so we now consider depression as a neurodegenerative disorder. And what that means is this is no longer a chemical imbalance, but this is actually an alteration in the brain itself and a degeneration of neurons within the brain. And so this is an important change in the way we view this particular disorder. One of the things we're going to talk about is what's called brain-derived neurotrophic factor. And BDNF, as we will be calling it from now on, is an important substance that can modulate this particular effect. So when we have stress or other neuronal insults, particularly we'll talk about stress, we get an increase in glucocorticoids or cortisol and reductions in BDNF. And as a result, we get atrophy and neuronal death. Antidepressants and other treatments we'll talk about increase serotonin and norepinephrine, also increase brain-derived neurotrophin factor, and decrease the release of glucocorticoids. So we get an increased survival, growth, and protection. And so these processes are going to underlie a lot of what we're going to be talking about in the coming lectures. So stress, injury, or illness can cause the loss of neurons and reductions in neurogenesis, as well as reduce prefrontal cortex dendritic spine density. So we see this in this sort of model of depression, where when we have a normal system here on the left, we have normal functioning CA3 neurons, normal functioning hippocampus. That stress increases in glucocorticoids and decreases in BDNF, then cause the atrophy or death of neurons. And so generally that's caused by stress. It can also be caused by viruses, neurotoxins, hypoglycemia, and hypoxia. So there are a variety of different ways in which the brain can be stressed. One of the things we'll talk about in upcoming lectures is that there are a number of things that can stress the brain, including something as simple as dehydration. There is evidence that being 1 liter down in the amount of water you should have brought in can actually act as a stressor on the brain. And so some fairly simple alterations in our lifestyle sometimes can help us out in this area. So antidepressants increase BDNF, decrease glucocorticoids, and increase both neurogenesis and neuronal survival. And we're going to talk about different types of antidepressants and also some potential alternatives to antidepressants by looking at the release of glucocorticoids and increases in brain-derived neurotrophic factor. So those are two important areas that we're going to be looking at in the upcoming lectures. So the open question we have is the role of genetic and epigenetic factors. And we really, at this point, believe that there isn't that much to genetics and depression. There may be something to genetics and anxiety and the stress associated that is the underlying cause of depression. But depression itself does not appear to have any sort of underlying genetic component at this point. So here's an overall model of this, that depression is a consequence of stress, that stress damages the brain and weakens its ability to recover. Those antidepressants relieve our depressed mood by acting at the cellular level to promote neural survival and reduce stress-induced neuronal damage. The immediate effect of antidepressants is to modulate neurotransmitter levels, but the ultimate targets are intracellular molecules responsible for maintenance of neuronal health and plasticity. So that's the overall current view of depression. So we're going to talk in a later lecture about how ketamine works to modulate this process. And the exciting thing about that ketamine treatment is it apparently has a very rapid effect. Within 24 hours, we see improvement in a number of patients. So that's something exciting to look forward to. So that gets us at the critical role of stress. That's the principal cause of depression. In particular, is uncontrollable stress. When you cannot control what's happening in your life, that's when we get the most stress. So oftentimes, this is where we're talking about people who are abuse victims because they can't control their environment, POWs, soldiers returning from war, because again, we're talking about uncontrollable stress. Even things like caregivers for chronic patients. I take care of my mother who has dementia, and that is an uncontrollable stressor in which you can't control the environment, and there's also no predicting it. So that's an important thing to keep in mind. So one of the things to understand also is that the hippocampus exerts top-down control of the HPA, or hypothalamic pituitary adrenal axis. And this is our primary stress system. So when you have a stress response, the HPA axis is what's causing this whole thing to kick in to drive. And so that adrenal cortex is the adrenal glands are what are releasing cortisol. What we see is because the hippocampus exerts top-down control of this function, or of this particular system, when we have reduced hippocampal functioning, we then get exacerbated effects of chronic stress because the hippocampus isn't controlling that stress response because it has been damaged by earlier stress responses. And so that's an important part of understanding this. So preventing depression from chronic stress involves reducing the neuronal damage through increases in BDNF and reductions in cortisol. And so one of the things we're going to definitely talk about is ways in which we can see reductions in the release of cortisol, but also ways in which we can increase the amount of BDNF associated with our brain. All right, well, that is a quick introduction to the modern theories of depression. And it's an exciting time because it really helps us understand how lifestyle factors, how stress in our environment, stress in our lives, can lead us to a major depressive episode. And so thinking about that becomes an important way to start thinking about ways in which we can treat depression that don't necessarily involve SSRIs. All right. Well, I will return with more information on antidepressant therapy in the upcoming lectures.